So starting with the first lecture number 1, functional anatomy. Easy lecture. This is very easy. Can you see the screen now?
Yes.
So in this lecture, this is basically the basic anatomy, physiological anatomy of the heart, where you are going to have like how many chambers are there, which valves are involved, and what are the functions of the valves of the heart. So circulatory system means heart, blood vessels, and blood. Although blood is taken as heme immune block, but heart and blood vessels are discussed in physiology here. Okay, there are two types of circulations, as you know, to and from the heart. One is pulmonary circulation, where the blood is going from right ventricle to the lungs. For what it is going? It is going for uh, oxygenation, to build with the oxygen, to load with the oxygen, because lungs contain oxygen, and that's why it will be loaded with oxygen in the pulmonary circulation. And from there, it will return in the form of systemic circulation to the from the heart to the all parts of the body. First, it will go there from right side of the heart to the lungs, get filled with or loaded with oxygen, comes back to the left atrium. This is all pulmonary circulation. And then from left ventricle to the aorta and to all parts of the body is the systemic circulation, where oxygenated blood is supplied to every part of the body. So these are the pictures. So we don't have to go in detail about the pictures. So here it is the anatomy only, that heart is a muscular organ, where it is lying. It has got base, apex, and so on and so forth. It's not so important. Here is the functional anatomy, that why heart is, what is the importance of heart being placed in the chest, which is having in front the sternum and behind is the vertebral column. So this will help us to do the cardiopulmonary resuscitation in case of emergency. When the heart stops or sudden cardiac arrest, then we can revive the patient if we perform cardiopulmonary resuscitation, because it is a muscular bag in between the two ribs. So we can press it like this. Okay, so we will not go in detail. So heart is a dual pump. It has got right side pump and left side pump. Right side pump means right ventricle pumping the blood to the lungs, and left side from the heart, left ventricle to all parts of the body. It has got two chambers, four chambers, two types. One is atria, that is upper chamber, and two are the ventricles, which are the lower chambers.
Doctor,
Yes.
I'm sorry to interrupt, but the slides are still on the first slide.
Why? I shared the slide, and for me, it is moving. Can you see now the picture of circulation?
Now it's moving. Yeah, it's on the heart circulation.
Good. Okay. You stopped me. Okay, but this is in generally, I just gave the commentary. Okay. Now,
Okay.
when I make it in slideshow, please inform me if it is not moving, huh?
Okay, definitely.
Okay, so this is how it shows that the deoxygenated blood, I will move it again. Like two drops are shown, that right atrium collects the blood from upper part through the superior vena cava, lower part of the body through the inferior vena cava. Both will open into the right atrium. Then from there, blood will go to the right ventricle and to the through the pulmonary artery to the lungs. Similarly, the blood which is oxygenated now from coming from the lungs, it will travel through the pulmonary veins to the left atrium, then to the left ventricle, and from left ventricle to the through the aorta to all parts of the body. Here in this picture, please see that there are valves. Whenever the the blood is moving from one chamber to another or from chamber to the blood vessel. So these are guarded by the valves. What is the function of the valves?
To prevent backflow of blood.
Yes, yes. So if the direction of the arrow is from here, if you see here, can you see my arrow? That is from superior. Maybe I will make it a torch or light, something like that. A laser pointer. Okay. So if we say this is the arrow, that is the blood is coming from upper part of the body and from the lower part of the body to the right atrium. And then from here, the blood will go to the right ventricle, sorry. This is guarded by two valves. This is guarded by the valves. This valve is known as, it is present in between atrium and the ventricle. So this is called as atrioventricular valve. It is on the right side, so we call it as right atrioventricular valve. So this is guarded by a valve. So this valve function to prevent the blood going from right ventricle to right atrium. It will not allow. It will just allow the blood to move from atrium to the ventricle, not vice versa. So this is the function of a valve. Similarly, on the left side, you will see that left atrium, and this is the down one is the left ventricle. So blood will move from left atrium to the left ventricle, and not vice versa. Not it will not go from ventricle to the atrium because it is guarded by the again the AV valves, that is atrioventricular valve, and it is left sided. Another name for left AV valve is mitral valve. Similarly, blood from the left ventricle will go to the aorta. Once it will start contracting, it will go to aorta, and it is guarded by a semilunar valve, which is known as aortic valve. So function of the valve is to prevent the blood moving in the opposite direction, the direction which was designed. Okay. And these valves are, AV valves are attached to the ventricular muscle through body tendoning. I will show you in the next slide. Okay. Now this picture shows you cut section of the ventricle. If the ventricles are cut at this place, you can see above, you will find that, yeah, image.
The image is still, it's not changing.
Not changing.
Yes.
Now this is the circulation. Can you see now?
No, it's still on the.
Still circulation?
Yes, still circulation for the valves. Yeah, okay,
Now
it
you will
changes now.
Yeah, now maybe it is stucking in between. I don't know. See here, this is a cut section of the ventricle. It shows that right side thickness of the right ventricular wall is thin as compared to the left ventricular wall. What is the reason? The reason is left ventricle wall become thick because it has to pump the blood against very high pressure and high resistance area. It will press this wall will contract to push the blood to the systemic circulation, which is high pressure, high resistance area. That's why the thickness will become more. Thickness will become more. You can see here, I will draw with a pen. So this thickness, why it is pen? There is a pen. I'm not able to write it. I don't know why. Maybe it is in the Teams meeting. That's why. So thickness of the left ventricular wall is more as compared to the right ventricular wall, because right ventricle is pumping the blood to the pulmonary circulation, where the pressure is not as high as in the systemic side. That's why they will not build up the muscle here. Whereas left ventricular wall becomes thick because it is pumping the blood against very high pressure and high resistance area. Got it? So this is the proof that left ventricle is pumping blood against high pressure, high resistance area. Same like if we go to the gym and we start working out with weightlifting. So if you lift a weight of, let's say, 1 kilogram, maybe for 1 year, if you are lifting, the muscle mass will not increase much. Yes, Lamia?
Doctor, a lot of the students cannot understand the things that you're saying because of the slides. They're not moving with the thing that you're explaining. So, can you upload the lecture to the Teams, or we can move to Zoom if that will be better?
No problem, no problem. But currently, can you see the cut section of the ventricle?
Yeah, now we can see it, but we cannot see the most
Same
moving.
same slide I am talking about.
Good.
Even still, I will upload it. No, don't worry. Just let me finish this point and then I will upload.
Okay, thank you, doctor.
So currently, I'm explaining why the left ventricle wall is thicker than the right, because right is pumping the blood in a pulmonary circulation, which is low pressure, low resistance area, whereas left ventricle is pumping the blood against high pressure, high resistance area, which is high pressure, high resistance. That's why the thickness will become more. Just like if we are lifting a weight of 1 kilogram, our muscle will not change much. Whereas if you start lifting a weight of, let's say, 25 kilogram dumbbell for maybe 1 week, then your muscle mass will become slightly more. So this is the same principle is here, that left ventricular wall is thicker than right. It suggests that there is a pressure difference where the ventricles are functioning, against which the ventricles are functioning. Now let me upload this chapter or slide on the Teams so that you can also move it. Okay. Let me upload. Where is the Teams meeting? Okay, let me share the second lecture now. 2 and 3 are together. Can you see the second lecture now? Electrophysiology on
Yeah,
your
just
screen.
Yes, doctor.
Second lecture, okay. In second lecture, basically, it requires much attention because it is about depolarization and repolarization. Slightly difficult to understand, okay? So what this lecture is about? Lecture is about what electrical changes are happening during each beat. In one beat, what is happening and what is happening in the next beat, or how the muscles are undergoing contraction. For any muscle to go under contraction, first it has to go depolarization. It has to go under depolarization. So how it is happening, we will see here. As I told you in the previous lecture, that there is no role of the nerves, autonomic nerves, in initiation of the impulse. Impulse is initiated within the heart. Only it is regulated by the action of autonomic nervous system. Okay. So heart beats rhythmically. What does it mean? That means whatever it is happening in one beat, it will be same will happen in the second beat, and with the same gap in the next beat. This is called as rhythmic pattern. So to understand that, we have to know that there are two types of muscle cells. Two types of cells, you can say, cardiac cells. One is contractile cell and another is non-contractile or just conducting cells. That means their function is not for increasing and decreasing the length, but for some electrical changes, or just like a wires, just like the wires, electrical wires connecting the switch with the bulb. Okay. 99% are contractile. They are doing pumping action, and they don't have their own action potential. It is the action potential from the autorhythmic cell will come there. So autorhythmic cell, they are not contractile. They are specialized for excitation and conduction of the potentials, and they are not responsible for own, you can say, the contraction. But they will contract the muscles. So there is a specific pathway is there, conducting pathway. We call it as the impulse will not move haphazardly from down to up or from right to left, but in a specific pattern. What is this pattern? Here in this picture, it shows that the different types of non-contractile cells is SA node, SA node, sinoatrial node, which is present in the right atrium at the opening of superior vena cava. Then there is a AV node, that is atrioventricular node, and both of them are connected by internodal pathway. Internodal pathway. So any electrical activity which is starting here will not go to the down other than these blue lines, And from there, from AV node, the impulse or electrical activity will pass to the ventricle through a special bundle, which is called as bundle of His or AV bundle, bundle of His or AV bundle, which will divide into two parts, right bundle branch and left bundle branch on two sides of the interventricular septum. And then it will run through whole the ventricular chamber and then pierce the thickness of the wall, that is the left and right wall, by the Purkinje fiber. So through this, the impulse is passing, and then it will depolarize or do electrical changes in the muscles. Okay. So SA node is also known as the pacemaker of the heart. SA node is known as the pacemaker of the heart because the rate of depolarization is the fastest one. Number of beats generated in SA node is the maximum one. That's why it is called as the pacemaker of the heart. Followed by internodal pathway, then followed by the atrioventricular node, which is a small present at the junction of at the lower border of the interatrial septum. Then comes the bundle of His, which will be piercing from the atria to the ventricle and then dividing into two branches, that is right as well as left bundle branches, and then it will become then it will pierce the muscle of the ventricle through Purkinje fiber. What is more important in understanding this autorhythmic cell is that why the SA node is the pacemaker. Why is the SA node is a pacemaker? Because it doesn't have, you can say pacemaker is because it doesn't have any stable resting membrane potential. Resting membrane potential means it's a horizontal line. When equal amount of positive and negative ions are moving or coming in and out of the cell, that time if you record, you will record a zero potential. Zero potential is a resting membrane potential. So it is not present in the autorhythmic cell or SA node. SA node, whenever it comes to the zero or at the resting level, it will move up. This is called as pacemaker potential. I will show you in the diagram. So it doesn't have a straight or horizontal line, one smooth horizontal line. It is always, whenever it touches here, -60, again, it starts to rise up to -40, which is the threshold. And after that, it will shoot up in the form of action potential. So this rising phase, this phase is known as slow depolarization, or another name is pacemaker potential. So it will not have resting membrane potential, rather than it will have slow depolarization phase, or it is also known as pacemaker potential. Why this pacemaker potential occurs? The reason is, you may ask me why it is not stable, why it is always moving up and not remaining at the straight line. It is due to the presence of sodium channels, which are known as funny sodium channels. So whenever potential reaches to -60, these channels will open. This will allow sodium to move in. Once the sodium will move in, the potential will become less negative. The potential will become less negative. So from -60, it will go to -55, -50, -45, like that. It will rise up just because the channels will be opening at this potential, at this level. So this is how it will be starting. And once it reaches to -40, then there will be action potential. So slow depolarization phase is known as pacemaker potential. So first half of the this slow depolarization is because of entry or influx of sodium ions. Whereas second half of the slope or this rising potential or the pacemaker potential is because of the entry of calcium channels, entry of calcium through the calcium channels. And these channels are known as transient calcium channel. They will open for very short time and then it will move in. Calcium will move in. So first, initially, sodium will move in, and second half, calcium will move in. Once it reaches to -40, then the different types of positive, and it will reach up to 0 and cross the 0. Reach up to 0 potential and cross the 0 line, maybe overshoot plus sign. At this point, the calciums will close and potassium channels will open. So potassium will move out. That is, efflux of potassium will cause the graph to go down. This is called as repolarization phase. First, the one which is coming down is called as the repolarization phase. This is due to the exit of potassium. Exit of potassium. So same thing will happen again in the next beat, that is in the next cycle. Once it will reach to -60, again sodium channels will open. Next half, calcium channels will open, and it will take the potential to the -40, which is threshold. So at threshold, calcium channels will open, and it will go towards the 0 side. Once it is at the 0, again potassium will open and it will come down. So this cycle is going on. It is going on. This is called as autorhythmic cells. Okay, autorhythmicity or pacemaker potential. Any difficulty in this?
No, it's obvious.
Okay. So here the causes are given for each phase. You can read it. One more thing. Okay. Every cell, like is the pacemaker potential, pacemaker of the heart, normal pacemaker, because the generation of action potential is maximum in SA node, that is 70 to 80 times per minute. Whereas similar function of AV node is there, but the number of action potentials will be 40 to 60 times per minute. Again, generation in this area will be 20 to 40 times per minute or 40 per minute. So the one which is having the highest number of action potential is known as the SA node or normal pacemaker of the heart. Okay. Here is the analogy showing you that, let's say, if these three are SA node, AV node, and Purkinje fiber, these are the generators. These are the one which will generate the potential. So suppose these are are the engine of a train. The train is containing the different bogies, and these bogies are nothing but the muscle cells. These are the conducting cells and these are the muscle cells. So there are three types of conducting cells are there: SA node, AV node, and Purkinje fiber. The speed of or the number of action potential by SA node is 70 beats per minute. The AV node is 50 beats per minute, and Purkinje fiber is 30 beats per minute or 30 times per minute. The one which is the fastest one will be the leader. So it will be the SA node will be the pacemaker of the heart. But what will happen if SA node get damaged? If SA node get damaged, who will take over? The next pacemaker. The next pacemaker is nothing but AV node.
If you know.
So if one pacemaker get damaged, second normal pacemaker, that is AV node, will take over. But only difference will be here is the heart rate will be slower. Here it was 70 beats per minute. Here it will become 50 beats per minute. Suppose in a rarest condition, suppose these two are get damaged. Suppose SA node and AV node, both of them are get damaged. The third engine will take the actions or will take the lead. But that time the heart rate will be slower than 50 because it is the Purkinje fiber. This is usually happen in damaging of the any area of the heart due to heart attack. Okay. Sometimes, other than these three pacemaker, even some muscles can start to twitch and give some action potential. These are called as ectopic pacemaker. Ectopic pacemaker. And these are usually associated with some disease of the heart, or maybe lack of sleep, or anxiety, or excess of caffeine or nicotine. Other than the normal pacemakers, some other tissues will start to twitch or give action potentials. So here is the analogy showing you what will be the speed of conduction when SA node is working, so 70 beats per minute. If AV node is working, it will be less, 50 beats per minute. If it is Purkinje fiber is working, then 30 beats per minute. But at the same time, you will also find atria is beating at a different speed because it is having normal SA node. Okay. As I told you, if these get damaged, suppose AV node get damaged or SA node get damaged, we will have a condition called as hard block. These conduction pathways, if there is a defect, we call it as a hard block. Either we call it as a SA nodal block when SA node is functioning, but it is not exciting the atria. This is called as blocked at the junction between the two sinoatria. AV junctional block, the block at the level of the AV node, AV junction. And AV nodal block is of three types, depending upon the severity: first degree, second degree, and third degree hard block. We call it as first degree block, or second degree hard block, or third degree hard block. This is related to AV node only. What is happening in first degree? First degree only, the conduction becomes slower. Conduction becomes slower between atria and the ventricle. In the second degree, what is happening? In the second degree, some beats are conducted, some impulses are conducted from atria to the ventricle, but some are non-conducted. Some are conducted and some are non-conducted. In the third degree, complete heart block. Atria will beat with its own speed and ventricle will beat at its own speed. Okay. Even the branches of the bundle of his can also be blocked. That is right bundle branch block or left bundle branch block. This you will understand in ECG mainly. So not necessary to remember here. Okay. This diagram showing you what is the effect of sympathetic and parasympathetic nerve on the heart rate. The first two beats are normal. Once the sympathetic is stimulated, the first three beats are normal here. The fourth and fifth beat, the slope is become very steep and it will be close to each other. That means the heart rate is increased. So during exercise or sympathetic stimulation, the heart rate is increases because of sympathetic stimulation, or the pre-potential is becoming less, okay, shorter. Similarly, if parasympathetic is stimulated, like the vagal nerve stimulation, the heart rate will become slower. Why it will become slower? Because the long pre-potential phase. Here, black is normal sympathetic stimulation. You will see the red line is going up with a short time, whereas in this is the dotted line is the vagal stimulation, but parasympathetic, it is taking long time, or the slope will become less steep. Duration becomes more and slope is less steep. That's why vagal nerve stimulation will lead to decreased heart rate. Okay. And during stimulation, when we say sympathetic stimulation, usually it is the neurotransmitter release. So during exercise, sympathetic stimulation leading to release of epinephrine and norepinephrine, which is causing the heart rate to become faster, increase in the beats per minute. Whereas parasympathetic stimulation leading to release of acetylcholine, and this will lead to slower heart rate or decreased heart rate. If you go in deep, why during sympathetic faster heart rate? Because easy influx or more influx of sodium, more influx of calcium is occurring, and less efflux or outgoing of the potassium is happening because of the sympathetic stimulation. Similarly, parasympathetic stimulation lead to decreased sodium influx, decreased calcium influx, and increase potassium efflux. That's why it will become slower and longer time. This is for parasympathetic. So heart rate is determined by the balance between sympathetic and parasympathetic stimulation. If normally at any given moment when you are not exercising, just in the normal activity, vagus is dominant than the sympathetic. Vagus or parasympathetic is dominant. The sympathetic will dominant when you start exercising or there is a fight or flight response. Okay. So at any given moment, parasympathetic is more stronger. What is happening with the transplanted heart? Transplanted heart rate is also regulated by epinephrine and norepinephrine, but the release is not directly on the heart, but rather than at some other places in the body. Many other places in the body, sympathetic and parasympathetic stimulation can lead to release of norepinephrine and epinephrine, which is coming through the blood and acting on the heart. This diagram shows how the conduction occurs. From SA node to AV node to bundle of phase, from bundle of phase to bundle branches, and from the bundle branches to the Purkinje fibers. Only thing to remember here is that SA node is the pacemaker of the heart because it has got faster or large number of action potentials are generated within a short period, within 1 minute. Whereas AV node, after AV node, the impulse will pass to the bundle branches. There is a delay. After depolarization of the atrium to the depolarization of the ventricle, there is a delay of about 0.1 second. this delay ensures or makes sure that atria will depolarize first, followed by ventricle. It's not like that both the ventricles and atria are depolarizing together. Because of this delay, it is possible to depolarize the atria first, then depolarize the ventricle later. If atria depolarize first, that means it will contract first. Even at the same time, ventricles are in relaxed position. So if they contract, the blood will be pushed and the ventricles will be filled. When the ventricles depolarize later, then they will contract and they will push the blood. So this delay is ensuring the proper filling of the ventricle. Otherwise, what will happen if both of them are atria and the ventricle, if they are depolarized together without any delay, then both will go in contraction. That means atria will contract and ventricle will contract. So blood will not go anywhere or ventricles will not get filled properly. Okay. So this AV nodal delay is important for making sure that ventricles are filled properly and they contract after atrium. Got it? Are you with me? So same point I was describing here, that there is a AV nodal delay of about 0.1 second. That means 100 millisecond. This delay is important to allow complete ventricular filling and it will contract after the atrium. Okay. Otherwise, what will happen if both of them will depolarize together or without any delay? Then there will be no filling of the ventricle and blood will not move anywhere. So followed by that, the ventricles will get excited. It will there will be faster conduction after AV node finishes. Then through the bundle branches, right and left bundle branches, the speed will become very high so that a large area of depolarization should be covered of the ventricle and all the ventricles will depolarize together and they will start to contract together. So slowest conduction is found in AV node, and this is important to make sure the ventricles fill properly. Whereas fastest conduction will be found in Purkinje fiber, which is about 2 to 4 meter per second, speed of conduction of the impulse. Why the conduction is slow in AV node? Because there may be less gap junctions so that it will take more time to pass the impulse from SA node to AV node. And the diameter of the fiber is also small, so it will take long time for the impulse to pass from one point to another point. Okay, now these are the phases of ventricular muscle action potential. Once the ventricular muscles get depolarized, it will have a zero phase, that is complete depolarization, going from resting membrane potential of -90 to reach to +20. And from there will be a plateau phase. This phase is known as plateau phase. And then after the plateau phase, it will start repolarizing. This is called as repolarization, that is phase 3. And then again the resting membrane potential. So this is about ventricular muscle action potential. So first is depolarization, which is caused by sodium entry into the cell, followed by early repolarization, then followed by slow repolarization, that is the plateau phase, and then the fast repolarization, that is the exit of potassium. Potassium is going out. And then there is a resting membrane potential. This gap, that is 250 millisecond, this gap, which is related to the plateau phase, in this phase, no second action potential will come. This is called as long refractory period. The whole phase is refractory. Refractory means second action potential will not be generated. If second action potential is not generated, then there will be no second contraction in this phase. So first contraction followed by relaxation, then second contraction. You cannot stimulate the cardiac muscle in between. Yani first contraction is going on, you start making second stimulus and it will go into second contraction. Not possible because of long refractory phase. And this long refractory phase is nothing but the corresponding to the plateau phase of the action potential. Same thing is shown here. This whole plateau phase is related to long refractory phase. Long refractory phase, make sure that the cardiac muscle will not go in titanization. Titanization means complete, only contraction without relaxation. Titanization means continuous contraction without relaxation. If muscles of ventricles go in contraction without any relaxation, it means there will be no filling. There will be no filling. Filling is allowed only during relaxation phase. So ventricular filling is not possible if cardiac muscle go in continuous contraction. To make sure that there is a long refractory period. So long refractory period, make sure that there is no second contraction before finishing the first contraction. And this is corresponding to the plateau phase of action potential. Same thing is shown here. No two stimulus can be summated in cardiac muscle because of the long refractory phase. Any difficulty in this? Are you with me?
Yes, doctor.
So
It's clear.
this is about lecture 2 and 3. Now let us go to lecture 4 and 5. I will project lecture 5 because most of the things are repeated. So I will project lecture number 5. So what is this lecture about? Lecture number 4 and 5 is about cardiac cycle. Okay. Cardiac cycle means any event which is happening in one beat, one muscle, one contraction of the ventricle is repeated in the next contraction. Any event which is happening in one contraction is repeated in the second contraction. So if you want to know how many times the heart beats in 1 minute, let's assume that heart is beating about 75 times per minute. Just for calculation purpose, we are taking a normal number, that is normal at rest. Suppose the heart rate is 75 beats per minute. That means 75 times in 60 seconds. 75 times in 60 seconds. So how much time is required for one beat? If you do the multiplication or division, like 60 divided by 75, you will get a number as 0.8, 0.8 second. So we say that whatever the event is happening in 0.8 second, it will be repeated in the next 0.8 second. So one event is about 0.8 seconds. So we call it as cardiac cycle time is 0.8 seconds. When we say cardiac cycle, that means contraction and relaxation, both phases. Contraction is known as systole. Relaxation is known as diastole. Now, as we say, there are two types of chambers, atrial chamber and ventricular chamber. So for that also we say atrial systole, that means atrial contraction, followed by atrial relaxation or atrial diastole. If we take ventricle as the second chamber, ventricular contraction is known as ventricular systole and ventricular relaxation is known as ventricular diastole. Now, out of these 0.8 second, how much time is given for ventricular systole? It is about 0.3 second. Out of 0.8 second, ventricle will remain in contracted state for 0.3 second, whereas remaining 0.5 second will be diastole, will be ventricular diastole. Now here, why we are not considering atrial event? Because atrial event will also be in the same time. They are also in the same time. That means at the last 1/3 of the ventricular diastole, atria starts to contract, which is called as atrial systole. And remaining ventricular systole and ventricular diastole, the atria will be in the relaxed state. In the relaxed state. So that's why we are not taking into consideration of the atrial event in the diagram of cardiac cycle. Okay, so I will show you here. These two green areas are known as the ventricular systole because this is 0.3 second time. And the central one is the ventricular diastole, which is about 0.5 seconds. Now in 0.3 second also, there is a special event is occurring in the first 0.01 second, 0.01 second. One special event is occurring. That is at the beginning of the ventricular systole, there is an area where the ventricle starts to contract as closed chamber. Ventricle starts to contract as closed chamber. We call it as isovolumetric contraction phase. Closed chamber means there is no blood is going in, coming in or going out. So there is no change in the volume. If there is no change in the volume, that means there is no change in the size of the ventricles. So that's why we call it as iso means same, metric means length or the area something. So it is contracting as if there is no change in the length. That's why it is called as isovolumetric contraction phase, followed by ejection phase. Once the ventricle starts contracting as a closed chamber, suddenly the pressure becomes very high and it is opening the aortic valve. So once the aortic valve is open, that is we are considering on the left side. Same events are happening on the right side also. As soon as the aortic valve open, the blood will be pushed out or ejected out. That's why it is called as ejection phase. So, but in the first half of the ejection phase, it will be faster movement. In the next half of the ejection phase, it is slower movement. Once the ejection happen, then again the valves will close. That is the aortic valve and pulmonary valve both will close. And at the same time, there is no opening of AV valve. That is mitral and tricuspid both are closed. And now ventricles are in the diastolic phase. So that's why it is called as isometric relaxation phase. That means iso means same, metric means length. No change in the length, but still the ventricles are in relaxed state. That is the diastole is beginning, but there is no change in the length because no valves are open at this moment. After that, first there is a rapid inflow phase. That means the AV valves will open and whatever blood collected in the atrium will be pushed to the ventricle. So ventricle filling will start, first rapid filling, followed by diastasis. That is whatever blood is coming from the pulmonary circulation will reach to the left atrium and then it will be poured into the left ventricle without any resistance. That's called as diastasis. But in the last 1/3, again the atria will contract. This is called as the atrial systole. And the same thing, the cycle will go on. So considering all these events, you have to think about how the pressure is changing in the ventricles. So I will show you the second diagram rather than this diagram. Okay, this diagram is, I will concentrate on. What is this diagram is about? For the pressure and volume changes. Pressure and volume changes in the ventricle. On the y-axis, what you will see here? Pressure. Left ventricular pressure. On the x-axis, what you are seeing here? Left ventricular volume. That's why the graph is known as pressure volume loop. Pressure volume loop. Okay. Once the ventricle starts relaxing, let's say we start with the diastole. So at the diastole, there is some blood is present. There is already some blood, residual blood is there, which is called as the or the end systolic volume. End systolic volume, the amount of the present at the end of the systole. So 65% of the 65%, 65 ml of the blood is present. Then ventricles are receiving blood from the atrium. So it is increasing. So if you go on the x-axis, you will see that there is increase in the volume from 65 to up to 135. So this is all diastole. Okay. What is happening here at point number 4? At point number 4, there is closure of AV valve. AV valves are now closed. Whatever blood is coming from the atrium now reach to the ventricle and the AV valves are closed. But you can say here is it left ventricle. So we'll say mitral valves are closed here and aortic valve are not yet open. Aortic valve are not yet open and ventricle starts to contract as closed chamber. That's why the pressure will be increasing very high. Suddenly, sharp rise in the pressure. This is a sharp rise in the pressure from, let's say, from here, around 20 millimeter of mercury, it reaches to 80 millimeter of mercury. So this is all up. This line is about isovolumetric contraction phase. What is happening after isovolumetric contraction? Suddenly the aortic valve will open. Blood is trying to go out and aortic valve is closed up till here. Now aortic valve will open at point number 6. What will happen? The blood will go out. If the blood goes out of the ventricle, volume will be changing from 135 to 65 again. This is the volume ejected. This is volume ejected here. At this point, once the whole of the blood, whatever the ventricular blood which is supposed to go out is ejected, and at that time the aortic valve will close and also the mitral valve is also closed. So both the valves are closed, ventricle will go in relaxation, but this time it is isovolumetric relaxation. So pressure is sharply decreasing from maybe around 120 till around 5 or 10 millimeter of mercury. At this point, at number 1 again, now which valve will open? AV valve will open. That is mitral valve will open. Yes, mitral valve will open and then it will start receiving the blood. So this is a diagram showing you pressure volume changes in the left ventricle. In exam, you may be asked to, by seeing the graph, you may be asked to what is happening at this point, number 1. What is happening at this point, number 4? What is happening at number 6? What is happening at number 8? You have to tell the answer. Okay. So this diagram is, you have to imagine what is happening here. Now, Even if you are imagining, you have to see what is there on the x-axis, left ventricular volume. What is there on the y-axis is the pressure. So based on the pressure and volume changes, you can imagine what is the condition of the ventricle or what is the condition of the valves at this point. This sharp rise is called as isovolumetric contraction. This sharp decrease is called as isovolumetric relaxation. This is opening of the AV valve. This is closure of the AV valve. This is opening of the aortic valve. This is closure of the aortic valve, like that. See here, it is shown here. Mitral valve means AV valve. Then mitral valve close. Then sharp rise, isovolumetric contraction, aortic valve will open. Then aortic valve will close, and there is isovolumetric relaxation phase. Okay. Again, it is shown here in the another diagram also what is happening at this point. Same thing is drawn here, relationship between volume and pressure in left ventricle. You can see here pressure difference. Numbers are not important for this picture. There is no, and we will not ask you the exactly what is the pressure in right atrium, what is the pressure in the left ventricle, but you can just remember that there is a decreased pressure on the right side, increased pressure on the left side. Okay, different terminologies you must remember. That is systolic volume. Okay, sorry, stroke volume and diastolic volume and systolic volume and ejection fraction. As I told you, it is given in the previous lecture, that is part 1 of the cardiac cycle. The amount of blood ejected by each ventricle in one beat is known as stroke volume. With one stroke, how much blood goes out is called as stroke volume. So whatever blood collected in the ventricle, total 100% did not go out. There is a small fraction goes out, or a fraction or a part goes out. That's why it is called as ejection fraction. So stroke volume in terms of percentage, we call it as ejection fraction. And it depends upon how much it is received. Suppose you receive in the ventricle before the contraction happens or at the end of the diastole. Suppose you receive 100 ml. And out of that, during contraction, the ventricles eject. Ventricular push the blood around 75%. That means ejection fraction will become 75. So like that, it can be known as end diastolic volume minus end systolic volume, or stroke volume divided by end diastolic volume. If you multiply it by 100, that means if you want to convert it into percentage, that time it becomes ejection fraction. Based on this value, ejection fraction, you can predict what is the condition of the ventricles. Because if the ejection fraction becomes less, that means ventricles are weak. And that's why the ejection fraction becomes decreased. Ventricular function can be predicted by knowing the ejection fraction. How you know the ejection fraction? By doing 2D echocardiography. Okay, based on the different events in the cardiac cycle, you might hear the sounds. These are called as heart sound. Basically, there are 4 heart sounds: S1, S2, S3, and S4. But normally, in a normal person and with the stethoscope, you can hear only S1 and S2, normal audible heart sounds, which are represented as lub and dup. S3 and S4, they may be audible in certain abnormal conditions. 3 may be sometimes 3 heart sound, third heart sound can be heard in a normal condition, but in infants or pregnant women, or maybe in fever or in exercise. But fourth heart sound is normally not heard. If it is heard, it is always abnormal. What is the cause of first heart sound? I told you in the in the lab also, that is cause of first heart sound is closure. Closing, huh? Not opening. Closure of mitral and tricuspid valve, or you can simply say closure of AV valve. Whereas second heart sound is due to closure of semilunar valves. Two semilunar valves are there, aortic and pulmonary. So heart sounds are produced due to the vibration set out by sudden stoppage of the flow of blood. Third heart sound is due to the first rapid filling phase. And fourth heart sound is due to the last rapid filling phase, or you can say the atrial contraction. And it is only possible when the ventricles are becoming stiff and you are pouring the blood. That time it will produce slightly louder fourth heart sound and it can be heard. So if you want to know where exactly the sounds are appearing, simply remember first heart sound at the beginning of the ventricular systole, second heart sound at the beginning of the ventricular diastole. So first heart sound is marking the systole starting. Second heart sound will indicate the ventricles are going in relaxation now. Whereas fourth heart sound is just before the first heart sound, and third will be in between the second and fourth hearts. This is the practical part where these sounds will be heard. Murmurs are the abnormal sounds due to turbulent blood flow. Nothing else. Okay. Thank you very much. So in cardiac cycle, what is important? In cardiac cycle, you must imagine. You have to not necessary to memorize everything, but if one cycle you understand, you will understand everything, what events are happening in this cycle. Okay. First of all, cycle is divided into systole and diastole. Cycle time is based on the number of beats per minute, that is heart rate. And basically ventricle events are recorded, that is ventricular systole and ventricular diastole. Atrial systole and atrial diastoles are masked. They are behind these two events, that is ventricular systole and ventricular diastole. Anything else? This diagram is also the same. Okay. In this diagram, showing you what are the mechanical events happening during the cardiac cycle and what are the electrical events are happening in the cardiac cycle. Only one electrical event is happening in the cardiac cycle, that is electrocardiogram, ECG. So in ECG, the ventricle, once the ventricles depolarizes, the ventricular depolarization. Okay, first we'll begin with the atrial depolarization. Atrial depolarization is marked by P wave on the ECG. The ECG waves are P wave, QRS complex, T wave. These are the only ECG waves. Okay, and they are repeated. With every beat, they are repeated. So P wave is caused by atrial depolarization, whereas QRS complex is marked by or are due to the ventricular depolarization. QRS complex due to ventricular depolarization. Then comes the ventricular repolarization, which is marked by T wave. So remember the cause of each wave. P wave, atrial depolarization, QRS complex, ventricular depolarization, and T wave is due to ventricular repolarization. R for rabbit. Okay. Any difficulty? Apart from this, I explained everything. I just revise whole lecture. If you have any difficulty other than this, you can ask me.
Thank you, doctor.
Thank you very much. Read the question properly in the exam and correlate with your knowledge and then answer. Don't blindly answer. First, read the question properly and accordingly you will you choose the answer.